Good afternoon. This is Colleen Watson. I want to thank everybody for joining us on Maximizing Medicaid Eligibility Outcomes. Thank you for taking the time to join us for this webinar. I want to just start by letting you know that if you have any questions during the webinar or if you're having any trouble logging in, you can send an email to webinars.health@alltran.com. And I'll say that again. So if you have any questions during the webinar, if you're having trouble logging in during the webinar, or if you anything that you think of, you can go to webinars.health@alltran.com. And that email address is also good if you have questions after the webinar as well. I think we will give people maybe 1 or 2 more minutes. Let me see. We have a decent number of attendees. Let's go ahead and get started. So Alltran has been doing webinars since 2015. It was actually FHS, or Financial Health Strategies, and Array Services Group. And we started with webinars in 2015 on various topics, co-hosted by industry experts. We also hosted multiple roundtable discussions, and we do make our recordings available. It takes about a week before they're uploaded to our website. And in July of 2016, last year, FHS and Array Services Group and J.C. Christensen merged to form Alltran. They actually merged before that, but we rebranded to form the name Alltran. And Alltran is a name that represents the all-inclusive nature of our companies. And So we merged in July of 2016, came up with the name Alltran. Represents the all-inclusive nature of our companies and the transformational force that we bring to the healthcare revenue cycle industry. We do have over 39 years of healthcare experience, and our clients, we believe, are going to benefit from this more singular focus. So again, any questions during the webinar? If your questions are related to the content, then you'll see a spot on the right-hand side under questions. You can click on there and then just go ahead and type your question in. So these are questions related to content, not like technical questions. Any questions related to content, type in on the right-hand side under questions. If it's something that's pertinent to what we're talking about right then and there, then I might go ahead and stop the webinar and address it. Maybe one of the slides was confusing, or if it's a good topic for discussion. If not, then we're going to have about 10 to 15 minutes at the end of the webinar to discuss all of the questions. So just so you know, if you type in a question, we don't get to it right away, we're probably going to get to it at the end of the webinar. Additionally, if you come up with a question after the webinar has ended, or if you're having any kind of technical difficulties whatsoever, you can go to webinars.health@alltran.com. So email webinars.health@alltran.com with any of your technical questions. Lastly, at the end of the webinar, we are going to do a little survey. We are going to ask you to participate in a little survey, and I do appreciate your participation. It helps us to kind of perfect our webinars on a go-forward basis. So I am Colleen Watson, Vice President Business Development. I've been in revenue cycle about 20 years. This says 15 years of healthcare sales experience, but I have about 20 years of revenue cycle experience. I've been with Alltran Health just over a year. Before that, I was with MDON, with Executive Health Resources, and I was with Passport Health Communications for about 10 years. I have a Bachelor of Science from Penn State, my MBA from St. Joseph's, and I am a CRCR member of HIM, HIMSS, and HFMA, and AHAM, and a few other organizations. Also joining us today, waiting for the next slide here, is Stacy Baumgart. Stacy is the Regional Manager of Medicaid Eligibility and Billing Operations here at Alltran. Stacy joined Alltran in 2011. It was Financial Health Strategies at that time. She was a Medicaid eligibility representative at a hospital in Buffalo. Because of her outstanding work, we actually requested that she relocate to the corporate office in Gaithersburg, Maryland. She was promoted to supervisor and then regional manager of Medicaid eligibility and billing operations. Stacy has a passion for healthcare, having worked in the industry for 15 years in various positions, including direct patient care, social work, patient access, Medicaid billing and auditing, and operations management. She has extensive knowledge of Medicaid regulations and services in many states. She holds dual degrees in biology and accounting from Deweyville College and Niagara County Community College. She's a national member of the American Association of Healthcare Administration Management, AHAM. I don't think I've ever said that whole word. And a member of Maryland and Virginia AHAM chapters, and received her CRCE certification in 2016. Also a member of HFMA, and as an All-Trend Regional Manager for Medicaid Eligibility Program Operations, Stacy is responsible for on-site patient screening by Medicaid eligibility specialists at a number of hospitals, efficient call center technology and operation, process improvement engineering, while ensuring the integrity of the patient-provider relationship, maintaining improved and predictable revenue returns, and establishing comprehensive and customized client-specific reporting. I promise we're not going to read every slide. Also joining us today is Linda Larner. Linda is the Revenue Cycle Director at Washington Health System since December of 2012, overseeing daily operations of patient access and the business office at the Washington Hospital and Washington Health System Green. Prior to joining Washington Health, Linda was with West Penn Allegheny Health System for 16 years in multiple capacities of revenue cycle leadership. Linda is an active co-chair of Healthcare Council of Western PA Accounts Receivable Committee and a member of both HFMA and AHAM. So to keep everybody engaged, throughout this webinar, we're going to ask a few poll questions. So question number 1, does your facility outsource Medicaid eligibility and enrollment, or do you handle it internally? So the polls are open, and I think that you can just click on your screen and answer that question. We actually are only going to have 3 poll questions, so don't think there's going to be too many of them. But it keeps everybody engaged. It also gives us a good idea of the audience that we have and what everybody is currently doing. Okay, so there we go. It looks like most of you do outsource your Medicaid eligibility, and then there's just a few of you that currently keep it in-house. Interesting. Okay. Moving on. So for the next part of the presentation, I'm going to hand it over to Stacy Baumgart. Again, she's our Medicaid eligibility in-house expert, if you will. And Stacy's going to go ahead and go through these slides. But if you should have any questions on content, please go ahead and type your questions in on the right-hand side of the screen. If you have any technical questions, email them to webinars.health@alltrend.com. Stacy?
Okay, great. Thank you, Colleen. Okay, so Medicaid eligibility. Just to start off talking a little bit about Medicaid, it's a joint federal and state program, and I know there are some changes going on right now that may make some of these slides a little outdated after maybe today, but we'll still go through them and kind of go over it and talk about the upcoming changes as well. So Medicaid is a joint program with federal. It's primarily a state program, but with federal regulations, some federal regulations in there. Medicaid is the single largest source of healthcare coverage in the United States. I know Medicare is also a big insurance provider, but Medicaid is also a very big source for healthcare coverage. When looking at Medicaid, you want to look at both financial and non-financial factors, and we're going to go more into that a little bit throughout this presentation and see what different kinds of guidelines vary. What guidelines are the same, and talk about the program in general. So, next slide. So basically, when you're looking at maximizing your eligibility outcomes, the first thing you want to look at is your screening process. And you want to look at your the consistency in your process. So, you know, inpatients, obviously, inpatient visits usually are high dollar accounts, so you really want to focus in on and making sure that you have a good, consistent screening process for your inpatients. But discharge patients and ED patients are also play a big factor, and you want to look at those processes as well. And then definitely pre-screening for scheduled visits and having some sort of talk off at the beginning before patients come in if it's a scheduled visit. Try to talk to them about the application process, any necessary documents, things like that. Another piece for screening is making sure that there's trained staff. So some states can have CACs or certified application counselors or facilitated enrollers. If you just have, you know, if you're a non-expanded state and you're just doing financial counseling and have financial counselors, making sure that they are trained and up to date on where to find regulations and what regulations are within the state or surrounding states or other states' Medicaid states that your facility accepts. Some necessary equipment. One of the things with the Affordable Care Act that I anticipate will probably continue with the American Health Care Act, I believe they're calling it now, is online application portals. Pretty much all applications are done online. There's a few in certain states that are still paper applications. Emergency Medicaid applications tend to be paper, but for the most part, a lot of states have moved everything else to online applications. So definitely electronics is another piece that you're going to want to look at, either laptops, tablets, so that way those things can be completed bedside. Applications can be completed bedside at that point in time. The other piece of the screening is not just the screening part and completing the application, but also looking at follow-up and how you follow up on those accounts. And setting up work queues. You know, if you're doing it internally, setting up work queues to make sure that those applications is not just submitted and forgotten about, and there are follow-ups, especially for discharge patients as well. But there are those follow-up pieces put in place. If you have, if you're outsourcing it, you know, seeing what kind of follow-up procedures that your company, your vendor does. Especially the home visits and going out into the community to try to get that cooperation and any necessary documents as well. So, next slide. So keeping up with regulations, and I sense that there's going to be some regulation changes coming very shortly. So what are you doing to keep up with the regulations? There's a lot of different things that CMS does to try to send out what the regulations are, any updates to them. They usually send them to a lot of providers. I know AHAM will send out a lot of things. HFMA typically sends out notices. If you're part of those kinds of organizations, they'll send out information as well on any regulation changes. But just kind of making sure that there's different resources and different places to go to keep up on the changes of the regulations. Next slide.
Okay, now we have our next poll question. If you do handle Medicaid internally, how strong is your strategy to keep your staff up to date on the latest regulations? Is it very strong? So you have constant, continued education on a regular basis? Somewhat? Do you monitor your staff knowledge, but you don't have a true formal process to make sure everybody's up to date? Or you really don't have a strategy at all? Your staff is kind of on their own? So please go ahead and answer those poll questions. Okay, so for those of you that are handling the Medicaid eligibility and enrollment internally, it looks like 50% have a very strong continued education program. 33% somewhat, and 17% your staff is on their own. Thank you.
Okay. So for right now in expanded states, they do have, there's the CACs, or Certified Application Counselors, are a certification that people can get to assist people in applicants in applying for Medicaid. So they do have some limited capabilities. Generally, their job is to solely assist with the application process. Some of the things that they are not able to do is to gain access to the federal and state databases, not allowed to make any kind of decisions on an account, and they're not allowed to represent the applicant in the case of an appeal for denials, or represent them in helping get documents. They're also not allowed to, and where we here where we write, influence applicants on when to apply. That mostly has to do with a lot of the retro period and what's most beneficial for the patient. It's not necessarily, they're still staying within the guidelines, but Medicaid guidelines, but there's different times that you can apply for retro period, for retro coverage, and depending on when you apply, there could be, there could be some coaching to the applicant on when to apply that's most beneficial for them. So that's still within the regulations. But CACs cannot do those pieces. Next slide. Another avenue for providers is to partner up with the Department of Social Services. Each state may call it something slightly different. Department of Family and Children's Office, the slightly different name, but the county department, to partner up with them and sometimes have them right on site. So there are a few more benefits to doing that. The DSS representatives can, do the interviews and complete the applications and enter them right into the state website. They can make decisions on whether they're approved or not approved. They can verify a lot of the documentation right then and there versus asking for verification for it. Some of the downsides to doing that, though, is their decision is their decision, and there's no checks and balances for their decision. So they obviously would not do a fair hearing. There's no accountability for how long they need to, how long it takes them to process an application. So there's each state and each program has certain guidelines of how long they are allowed to process an application. So if the DSS representative that is partnered with the facility takes too long, there is no checks and balances for that piece. If they deny a case that they shouldn't have denied, again, there's no checks and balances for that piece. And they typically don't go out and seek documents like you could if you were doing it internally or if you had a vendor doing it. They also, again, cannot coach applicants on when to apply. They just see the person that day and do the application and assess them that day. So some of the things, there is a little more benefit to partnering with the Department of Social Services, but there's still some areas of that there could be improvements. Next slide. Okay, so these next slides are going to start going into a little bit more of the different programs that Medicaid offers. But initially, the first thing that you want to look at for qualifying for Medicaid is there's three different factors. There's citizenship and residency that you want to look at. Then you need to make sure they meet a Medicaid category, and each state has different categories. And then there's the financial requirements. So there's non-financial and financial requirements. And the financial requirements, depending on the category, they all have income requirements, but some may also have resource requirements. So next slide. Just quickly, citizenship and residency. There's different categories for the residency requirements. Some people have a 5-year waiting period. Some people do not. In general, for most states, there's a few states that nobody has the 5-year waiting period, and then there's a few states that waiting period is a little bit longer. But in general, permanent residents have a 5-year waiting period, and then there's some other asylees, refugees, things like that, that do not have to wait that 5-year waiting period. Legal immigrants is one category that we see, I've seen a little bit in hospitals, people here on tours, visas, they're here legally in our country, but not citizens. Unfortunately, their only coverage is through the marketplace. They cannot get Medicaid. But then we get to the illegal or unauthorized aliens, and they have that emergency Medicaid services that I spoke about at the beginning, where they can get emergency coverage as long as they meet all the other requirements. Their visit also has to be emergent, so life or limb threatening, and they only have coverage for those dates of service until they're stable. Next slide, please. Okay, so a little more into the Medicaid program. Next slide, please. So there's, in general, there's about 4 different categories. There's some overlapping in the categories, but we'll talk about the 4 big topics. So next slide. The first one is single adults and childless couples, and this is a category that was mostly addressed for the expansion in the expanded states. This is typically in non-expanded states, and depending on what kind of changes come about in the repeal and replace or with the new administration, this category might not be a category again, but this is your single adults that are typically 21 to 64, that do not have any minor children, that are not disabled, and they generally do not meet any other criteria. In some states, these individuals are not covered, but in expanded states currently they are covered. And they use the modified adjusted gross income calculations, or MAGI, which is similar to the tax returns, and that's how they calculate their income. So this is one category that is typically only in the expanded states currently. Next slide. Categorically and optionally categorically needy group. This is traditional Medicaid. This slide in the medically needy is traditional Medicaid. This is where most states, this is a program that is covered in all states. Well, the categorically group, but this is your pregnant women, your children under the age of 19, your 65 and older, disabled individuals, blind individuals, and then there's a couple other programs like your end-stage renal disease, breast and cervical cancer. There's some other programs that also fall under here. Typically, most of the individuals that fall under this group also have resource guidelines, so that's another factor that comes into play. Again, emergency Medicaid is available in any of these categories as long as the category is available in that state and as long as the service is emergent. Next slide. And the medically needy, this group is reserved for individuals that are disabled, blind, or 65 and older. This is if someone needs to complete a spend down. So if their income is too high, individuals in this group can spend down their income, which, there's some calculations that makes it similar to like a deductible, I guess is the way to look at it. It's similar to a deductible, and they'll be responsible for that spend down amount, and then they'll have coverage after that. So this is just another group that the aged, blind, and disabled individuals can fall under if they need to spend down some income. Typically, you use this group for people that have very high medical bills. They might be, and their Medicare might have been exhausted, so now they don't have Medicare coverage, again, incurring very high medical bills. Resource limits also apply with this group. Next slide. Then there's Medicare beneficiaries, and there's some programs that are available to Medicare beneficiaries that typically have a little bit higher of an income guideline and a higher resource guideline. So there's the QMB, or the Qualified Medicare Beneficiary. This group, I believe, is 100% of the federal poverty level, and this one covers the Medicare premiums as well as acts as a secondary insurance for copays and deductibles for Medicare. Then there's the SLMB group, the Specified Low-Income Medicare Beneficiary. This one does not do the copays and deductibles, but it does pay the Medicare Part B premium for the individual, so it does help them with having a little bit more money in their pocket. And then the QI, or the Qualified Individual group, is similar to the SLMB group. It just has a different funding bucket, so when funds run out, those individuals don't have coverage. There's also resource limits for this group, and then this group obviously is also eligible to do the spend down, but they then would go under a different category. So Medicaid has several categories, and sometimes people can meet different ones, and it's really just up to the person screening them and the person completing the application to really understand the different programs and where they would fall in those programs to get them the coverage that's most appropriate. So next slide. Disability. So disability is another thing that Medicaid can look at. If someone wants to qualify for Medicaid under, if their age is 21 to 64, but they're saying they're disabled and they have not been deemed disabled by Social Security. Medicaid regulations for disability is very similar to the regulations for Social Security in most states. Typically, when you are submitting an application for Medicaid and for the person to be determined under the disability categories, most states have their own state review process, and that typically takes a lot less time than Social Security. Some states rely solely on Social Security, so it can take a long time to get decisions in those cases. Obviously, if the state offers a state review one, that's typically 90 days decision versus a year or two, depending on how many appeals there are for Social Security. So it really does vary from state to state how they make determinations. Typically, if an individual is applying for Medicaid under the criteria of being disabled, even though the state will review their medical records to determine disability, they typically also want them to apply for Social Security as well. So that's just something to keep in mind, that when looking at different partners, people to partner up with, or resources in the community. Next slide. And the Children's Health Insurance Program. So this is under a state program. There's a couple different things that are available under CHIP. So you can do the CHIP program, under which the state receives federal funding, and then there's the Medicaid expansion CHIP, and then there's a combination CHIP. So CHIP typically has higher income guidelines. It's not quite Medicaid. It's usually when individuals, when parents have higher income guidelines for Medicaid but are still under a certain threshold. Some states are up to 400% of the federal poverty level. And it's just another program that's out there for children under the age of 19 to get coverage. Sometimes there's premiums associated with it, usually a few dollars a month, but sometimes there's premiums associated with this program as well. Next slide. So income eligibility requirements. Each category, next slide. Each category is has different income guidelines. Each state has different income guidelines. Typically, most states follow the same income guidelines, but there are some that have a little bit higher or a little bit lower. There's some states that make exceptions. So really knowing the regulations in your area and in your surrounding areas. If you're near the border of another state, or you might get a lot of people traveling to your facility from other states, it's always good to know the regulations for those states as well. So the next few slides are just some maps of the country looking at different income guidelines for different states. So this one is for CHIP, and these are as of January 2017. This one is for pregnant women. So pregnant women typically have a higher income guideline, similar to children under the age of 19. They tend to have higher income guidelines. Next slide. So this one is for parents of dependent children. And as you can see on this one, a lot of states have, if they've expanded, that's typically the 138%. So a lot of those purple states are expanded states. But the other ones you can see, the parents, so that's usually your low-income family and children states. Parents of the children tend to have a lot lower of an income guideline unless if the mother is pregnant. Then it's a different category. But they tend to be a lot lower under the federal poverty level. Next slide. And then this is, again, for the groups, the single individuals, the childless couples that are 21 to 64. And again, a lot of the purple is the expanded states, a lot of the blue is non-expanded states, and then there is one state. And if you'll go to the next slide. There is one state that did not expand, but did, there's one state that did not expand, but it does cover adults. So next slide. The presumptive eligibility, this is another way that facilities can get additional funding. Presumptive eligibility, the facility has to apply for it, and you have to become a PE entity. And then once you do that, you can submit presumptive eligibility applications. And when you do that, you also have to ensure that you know your state's regulations as far as maintaining their conversion rates. So there's a conversion rate of the percentage of full applications and the percentage of approvals. So for all your presumptive eligibilities that you submit, you have to have a certain percent of those individuals that submit full applications, and of those full applications, there needs to be a certain percentage of them approved. And each state's different. They can be as low as 80% for each and up as high as 95% for some states. But if you, so the state will audit that and monitor that. And but typically what happens if you don't meet those percentages, they just take away your PE ability. So next slide. And then this slide, there's a lot of content on here, but I'll just briefly go over it. It's just evaluating your the effectiveness of your program. So again, if you're insourcing it or outsourcing it, there are some things to look at. So again, the applications, the denials, delays, and appeals, that's the fair hearing process. So are you currently doing that in-house? Is your vendor doing that? Those are some things to look at. Tracking and reporting, obviously you're going to want to track your applications and to see what's going on with them. Reporting, you're going to want to see, are you within the industry standards? You want to look at your different benchmarks. You know, how long is it taking applications to be submitted? How long is it taking them to be approved? How long is it taking them to be paid? And making sure that those numbers are within, you know, the norms for each area. Again, looking at your resources, that you have online application portals, education, partnering up with local agencies, like I was talking before, the Department of Social Services, legal aid, Social Security offices, Department of Aging, those kind of places. And then looking at auditing. How are you auditing? Are you auditing yourself internally? Are you auditing your vendor? Are you looking at, are you making everyone accountable to the standards that you're putting in place, whether it's internally or externally? A lot of people are outsourcing. So is your vendor up to the standards that you would expect if you were doing it internally? And then looking at outsourcing. So looking at contracting with the Department of Social Services. There are some grants, there were some grants out there for CACs or navigators to come on site, or again doing a Medicaid vendor. And also identifying the work that you want to outsource. So, and looking at the pros and cons and how that fits into your facility. Next slide. So what does the future hold for us? Next slide. Basically, we're not sure. We are trying to, stay up to date with all the changes. I know there were some meetings going on today and trying to get things passed in the government. So we're just not quite sure, just like everyone else, just trying to stay on top of it as best as possible. Next slide. And the only constant is change. So here's some things that it's looking like, that 24 million Americans will lose their coverage in the next decade. And so they're looking at the expanded Medicaid would terminate. But we'll have to see. We're just trying to stay up to date just like everyone else and see what kind of changes are going to come about in the near future. Next slide.
So now we have our third poll question. Hopefully you guys are all still awake out there. How do you think your organization will be impacted by the ACA repeal or replacement? Positive, negative, too soon to tell, or neutral? We've been through this before. And it's a timely question, indeed, as the vote is scheduled for this evening. I actually thought it was supposed to happen this afternoon, but I found out it's going to happen this evening. And from everything I'm reading, it doesn't look like it's going to pass the first muster. It doesn't look like it's going to go through tonight. At this point, it has about a 17% approval rating nationally. So there's a lot of GOP holdouts from what I'm reading. So we will see. Like Stacy said, we don't know what the future holds. There's a lot of uncertainty out there, but it does look like a significant number of Medicaid enrollees are going to lose coverage, about 20 million if this does pass. So it's some scary times. And based on the answers, I think you guys all agree that we don't know what we don't know. Too soon to tell. Let's see how it plays out, 43%. Interesting. Next slide. So this slide is going to talk about the benefits of outsourcing Medicaid. And you know what? Before I get into the various benefits, what I'd like to do is invite Linda Larner to speak. Linda joins us from Washington Health System, and we're just so happy and appreciative that she was able to join today. Linda, why don't you talk about your experience with using what was FHS but now Altran? Give us some insight on Washington Health System.
And thanks, Colleen. It's an opportunity to be able to participate in the webinar and speak to some of the benefits that we've seen at Washington Health System. Washington Health System has outsourced Medicaid eligibility for a great number of years. As a matter of fact, FHS and now Altran has been our vendor of choice for 15 years, since 2002. For some providers, as the first poll showed, that do not currently outsource, and perhaps for others that do and may be looking to make some changes, I just wanted to tell you at a high level some observations and some of the benefits Washington Health System gets from outsourcing with Alltran. We get an on-site MA eligibility representative or representatives that are subject matter experts. We have confidence in their ability to relate to the population and get the job done. The representatives work with patients and their schedules to assist them with their MA applications, appeals, and charity care for those that are found ineligible for Medicaid, sometimes as early in the screening process. The eligibility representatives establish good working relationships with the DPW offices or the assistance offices that help with the efficiency of the processing of the application. We've also found that they're a good fit with our organization. They fit in well with hospital staff. They ensure good relations. Having the service promotes patient satisfaction, or patients feel the rep is an advocate for them. Outsourcing, to me, is cost-effective. The reps are recruited and trained by the outsourced vendor. They also keep them updated on ever-changing regulations. We've had excellent, and no lie, excellent application to eligibility turnaround timeframes, 14 to 28 days on average, sometimes much less. They provide customizable reporting. They meet a provider's needs. I know they've met mine. They've surpassed my needs as far as reporting is concerned. And there's a high level of trust that's been developed over the last 15 years with my vendor of choice. So just a couple things. And thanks, Colleen.
Well, thank you so much. Thank you so much for that, Linda. We really do appreciate it. And hopefully, while Linda was talking, you had an opportunity to look at the slide here and see the optimized results. We've been doing this for over 30 years, so we do have the industry expertise. We're the experts in our field. And as Linda mentioned, we do all of the training for our staff, for the on-site staff at the hospitals, and also for the support staff back in Gaithersburg, Maryland. We have advanced screening technology. We track the applications from start to completion. We handle any denials, delays, appeals, and we have a very strong track record of winning those appeals. We handle the reporting, as Linda said, and then we also, because this is what we do day in and day out, we have great relationships with federal, state, and local agencies. In most cases, you can submit the applications electronically, but there's certain types of applications that need to be hand-delivered. Illegal aliens, emergency Medicaid, things like that. Sometimes they need to be hand-delivered, and we can do that. We're sort of the boots on the street. We can go out and meet with the clients, meet with the patients, get the information needed. You can go to the next slide. So, benefits of a dedicated specialist. So, I think it's really paramount to have a dedicated specialist on site, that this is all that they're going to do, for a variety of reasons. The specialists are going to work with the patients and the providers. They're there for the patients. They see it as a customer service, the patients do, and their families, that there's somebody there that's going to assist them in applying for their application. Let's face it, the people in the hospitals are sick. The application process can be really daunting. To have an expert there to assist them with that is just a lifesaver. Then that allows your staff to focus on other areas, probably speeding up your revenue cycle. So it increases patient satisfaction as the applications are completed and approved. Provides coverage that's going to follow those patients. They're going to take it with them. They're going to be covered in the future. So again, patient satisfaction, increased revenue cycle, and there's no startup costs. All the fees are contingency based, so that's another benefit. Go to the next slide. So our eligibility program, Linda talked about it probably way better than I can, but like I said, we've been doing this since 1984. We do have on-site staff to assist patients and families. 90 days or less for resolution for pretty much all Medicaid accounts. The average is 47 days. That's from time we meet with the patient till time the bill is paid. Linda gave some different numbers than that, which was a positive, and I think that is probably a national average. But you know, my experience and what I've heard people say is it's much less than that. We represent patients from start to finish, from the time they're in the hospital, the ED, or pre-service, through appeals, fair hearing trials, everything. We also can provide assistance with charity care applications, and that's really customized to the hospital. Some hospitals give us full charity care application permission. Some have a financial threshold there. One of the key differentiators, I think, is that we assume responsibility for assembling all required documentation. That's quite a task. So sometimes patients don't have all of the information. Sometimes patients are too sick to provide the information. We have to work with family members. They're discharged. We have to meet a patient or their family member, at their home, at the local McDonald's for safety reasons, what have you. But we do what needs to be done to get the application complete and submitted in a timely manner, and we monitor every application to completion. We hold full accountability for every application that we touch. Every single one is audited and reported back to the provider that we're working for. You can go to the next slide. The eligibility and verification process, it's probably a lot of the same, and this is somewhat intuitive, but first we identify if a patient is eligible for Medicaid. And if you were listening to Stacy's portion of the webinar in the beginning talking about the various regulations, no easy task. The regulations vary state to state, and seemingly day to day in the era that we're living in, we don't know what the future holds. But we identify if they're going to be eligible for Medicaid, assist the patients in completing the applications, gather all of the information. We'll provide transportation, translators if there's a language barrier. We do, like I said, whatever needs to be done to get the application complete. If there's any issues with the application, any kind of denials, we will file for a fair hearing or an appeal to ensure proper processing of the application. And then prompt notification of approvals so the claim can be billed for payment. So that's the reporting back to the providers, verify the coverage, obtain any additional billing documentation as needed. You can go to the next slide. So the on-site Medicaid eligibility specialist, I'm sorry, I'm looking at questions here. So the hiring process, we do the recruiting and screen all of the candidates, and the providers can be as involved or not in that hiring process. Some like to be really involved, and some like to leave it to us, and that's fine. But however it's done, we make sure that the employees go through all of the appropriate training, both the all-trans training and the provider training, be it on their HIS system, HIPAA, what have you. The on-site staff, they handle the daily interactions with patients, assist applicants to apply for benefits, act as the attorney in fact, obtain general releases, and obtain necessary documentation. Next slide. Oh, we are at the end. I didn't even realize. Well, I want to thank everybody for their time today. We have about 10 minutes left for questions. So I see some coming in now, and I would encourage you to please type in your questions on the right-hand side. I also want to remind everybody of two things. There's a handout tab on the right, so you can click on that and you can download this webinar. And then also, as I mentioned before, at the end of the webinar, when we close this out, there's going to be a survey, and I would encourage you to please take the time to do the survey. It really does help us out a lot. So I appreciate that. So let's see, the first question is full outsource, or can you do a partial outsource? So I guess the question is, if somebody utilizes Alltran, do they need to send us all of their patients, or can they do just keep some in-house and do a partial outsource? So the answer to that is you can do either. You can send us partial. You can do like an alpha split. You can send us the high dollar cases, the low dollar cases, what have you. It doesn't have to be an all or none. And then we have some systems that have sort of a two-vendor approach. The two-vendor approach, I think, is really unique in that sometimes it's an alpha split between two vendors. Sometimes it's almost like a champion-challenger type situation where they start off as an alpha split, but then the vendor that does a better job, I guess, for lack of a better term, gets another letter of the alphabet. So that is pretty unique. And then a lot of times if there's a two-vendor approach and one vendor does not get an applicant approved, then that will flip over to the other vendor, and then they could try to get approval. So that's sort of like an internal audit for every single case that comes in. All right, I'm looking at another question. Average time from patient to payment. Hey, Stacy, can you take that one for me?
I'm trying to expand it, and I'm not able to expand it. If you could just read the question.
Yeah, I was having a hard time seeing it as well. But I guess the question is, what is the average time from when a patient is seen by one of our eligibility specialists to when the claim is adjudicated, to when the payment is received?
It depends on, so the average time from when we accept the account to when it's paid, correct? Just to make sure I'm answering the correct question. Okay, I think so. So it depends on the category, but on average, I would say about 45 days from when we accept it to payment. Obviously, if it's a Social Security application or a disability application, it may take longer. Expanded Medicaid could take significantly less. Our approval rates, our approval days typically depend on, again, the category that we're talking about. So expanded states tend to see lower, less days, like Linda was talking about. And then non-expanded states where it's a little more traditional Medicaid is where we get closer to that 45-7-day mark.
Thank you for that, Stacy. I appreciate it. Do we have any other questions? I kind of have a question for the group I'd like to throw out there. When you're considering a vendor, an outsourced vendor, what are the top drivers you look at to select your vendor? So I'm waiting for somebody to respond. It's like crickets in here. So you can go ahead and type in the questions section, or I guess you could do it in the chat section if you prefer. But go ahead and type in the question section your response. And it looks like we have about 5 more minutes. So let me just first thank Linda Larner and Stacy Baumgart. Our contact information is on the screen. Stacy, Linda, do you guys have any final thoughts?
Nothing from me. Thank you again. I appreciate being a participant.
Nope. Again, thank you, Linda, for joining us, and thanks for everyone listening to me hear me talk about Medicaid.
And again, if you think of any questions after we disconnect, you can always you can email them to webinars.health webinars.alltran.com. That email address, again, is webinars.health@alltran.com. And you can also download a copy of this on the right-hand side where it says handouts. You can click on that and download the PDF of this presentation. Thank you so much for your time today. We appreciate you spending this hour with us, and have a wonderful day.